All right, if I can ask everybody to go ahead and take a seat, we're going to get started here in a minute. Like to call the meeting to order. We'll start with roll call.
Mr. Allen?
Present.
Mr. Norwood?
Here.
Mr. Ezell?
Here.
Mr. Waddell?
Here.
Mr. Stallings?
Here.
Mr. Mason?
Here.
Mayor Pankinen?
Here. Okay, item number 2, at the Commissioner's request, discuss any item of concern on the rescheduled regular session agenda of December 1st, 2020. All right, seeing none. Item 3, study items 3.1, discuss the current COVID-19 situation. We have several speakers from different parts of the health community. They're going to address us right now, and we'll talk a little bit more in the regular session later, but we kind of wanted to get an update from there. So first, I'd like to ask Maggie Jackson to come forward.
Good evening, Commissioners and Mayor. Thank you again for having me. And this is a study session, so I'm ready to study. I brought a lot of information for you tonight, including an update on our current COVID situation. I'm going to remove my mask because I would like to make sure I'm speaking clearly, but I recommend no one touching the microphone. So I'm Maggie Jackson. I also have invited Jan Fox. She is the Regional Administrative Director for our district that covers Garfield County. She is on the Zoom call there. And so she is my boss, and she's able to correct me if I'm wrong and also field additional questions. And I'm glad to have her here and her support tonight. And I know there are many lenses through which you all have to make decisions. And I don't envy you and appreciate you taking the time to hear a scientific update. The lens through which I see the COVID situation is through epidemiology and public health. If it matters to anyone, I have a bachelor's in biochemistry and molecular biology from Oklahoma State, and I have a master's in public health from OU. So no politics here, I can be on both sides. I just love public health and love this community. So I'm gonna dive in just with an update. Currently, we have 678 active cases of COVID-19 in Garfield County. We have 609 in Enid, and I broke it down into the zip codes up there. You can see 73703 has 358 active cases, and 701 has 236 active cases, but they have a smaller population. But as you can see from that graph, we have had a rapid increase in our average new cases. That purple line follows a 7-day trend. So it is, the spikes are individual days of new cases, and the purple line is the average. If you're curious about our racial or age breakdown of cases, if you look on the right, we do have a disproportionate impact of COVID-19 on some of our minority populations, including Asian Pacific Islander and our Black and African American communities. We have most of our cases, if you look at the pie chart on the right, in that 18 to 35 group. That's that group that they're getting out, they're living life, they are not concerned about being severely sick, and they are the majority of our infections. Not majority, they represent a bigger piece of our infections. This purple line is our hospitalizations, and there's a slight delay when these get reported. So it may be a week or two behind, but I have that we have 172 people reporting they've ever been hospitalized. And that we had a large spike early in August, but it has generally coincided. It was about 8% back in August, and now it's about 4% of our cases. So some good news, there. I don't bring gloom and doom. Our case fatality is getting better. Our hospitalizations are getting better. Our hospitals that will speak after me they have the state-of-the-art treatments. They are up to date with the latest ways to take care of patients here in Enid. So I know that we are able to take care of those who are hospitalized, but unfortunately, we're still seeing people die. We're at 37 deaths now. So for the county, that's a 0.9% case fatality. So that's improved. But we have so many cases. So our case fatality rate, the number of people dying per the number of cases, is going down. But as you can see in 73701, we've had at the very bottom there, we've had 23 deaths, and that represents a 1.34% case fatality. So Unfortunately, in that zip code, we are seeing a more severe impact.
What do you attribute that to?
It could be related to the median income, the access to healthcare. We do have higher rates of people who don't have insurance in that zip code. We have higher rates of comorbidities that might be in that zip code. I don't have that with me, but I know that just off the hand that. And we do have median income differences between 703 and 01. So that can make a difference. Where people live makes a difference in their health. Okay. Click. Come on here. There we go. So just wanted to show you the whole state for Oklahoma. This is the number of people admitted to the hospital across the state for COVID-19. So it's a rapid increase over the last few months, and I'll let the hospital speak for themselves about where they stand. But I know that we are in line with the state with seeing lots of people going to the hospital. Okay, I brought a lot of data, like I said, but on the left side, that map is showing the percent positivity for every county in Oklahoma. So that's out of all the testing we're doing, how many people are positive. It's in the middle there. We are at a 27.8% positivity. That is very high. And you might have heard lately, I think states like New York are at 2%, somewhere in there. So it does indicate that we might need more testing, and it just indicates we have a lot of people positive, and it's growing. That graph at the very bottom shows it's growing, and Northwest Oklahoma, you can see, is a little bit worse off.
Is that only PCR tests? Does the epidemiologist office report any of the other testing methods in that data?
For the PCR rates, for the percent positivity, I believe we're using just PCR tests. That would not include antigen tests.
How much of the testing that happens in the community is antigen as opposed to PCR?
That's a great question. I actually can't speak to that. I would like to know that as well.
Do the antigen tests not report to the State Department of Health?
They do, yes, okay. Yes. So antigen testing is a different method. You might, most of them are rapid tests, which many of our healthcare providers are using. They're very accurate in detecting positives. And they're originally they're called probable positives technically. In our case numbers, they are reflected as a case. And again, a case is one person. It's not one lab result. It's one person. All the lab results get merged into one case.
Okay, thank you.
Jan might know more about that. Maybe we can ask her at the end. So this is just a reminder. It's a little hard to read, but it is a reminder that our folks that are in the older age groups and have comorbidities are more likely to be hospitalized and more likely to die. So I didn't bring all the data with me today, but we know in Garfield County, we have a 46% obesity rate. We have high rates of diabetes, heart disease, kidney disease, and liver disease, which are all the comorbidities that put you at a higher risk of severe illness and death. This is a little hard to read too, but I wanted to include just a comparison that the map on my left side shows I can't read it now, it's too far away. The reported deaths per 100,000 population in the last 7 days. So you can see the counties in Oklahoma that have had quite a surge in deaths. So we did have 4 deaths reported last week. And on the right side is the percent change in cases from the last week. Sorry, I can hardly read it, but you can see in Northwest Oklahoma, we're in a group where we are all kind of seeing a surge in new cases. Let's skip through that. All right, so there are many community mitigation recommendations. We've already gone through several of those, including shutdowns and recommending social distancing. But today we're here to talk about masks. So I'm going to just share the data that I have on what we know about the infection of COVID-19 and how it spreads. This is just a simple little drawing of that little time period when you are exposed, your viral load increases, and you are contagious before your symptoms begin. You're also can be contagious for up to 48 hours before you might even test positive. So that's the premise by which we have a different need for COVID-19 than flu, than other viral illnesses that we have. It is contagious earlier than those other illnesses. So we have a lot of research that SARS-CoV-2 infections are spread by people without symptoms as well. They can either be asymptomatic their whole time they are positive, or they can be pre-symptomatic. So I probably need to go a little faster. So this is just a reminder that we can see 24% of infections were from people that never had symptoms. So I think we all know that by now, but I wanted to reiterate that's why we're talking about masks. So again, this is another simple picture that you are contagious before you feel sick, before you know you're sick. So I've heard a lot of people complain, why would you wear a mask when you're not sick? And this is why, because you can transmit the virus before you know you can. So just the research we know about how infection is spread. We know that it can be present in fecal oral matter. It can be present in aerosol droplets, which are tiny little droplets that can spread very far. But most infection comes from larger droplets that come from talking, breathing, and singing, yelling. They can also, of course, come from coughing and sneezing, but for someone who doesn't have symptoms, this is a chart that shows that the louder you sing and the louder you talk, the more droplets are emitted from your mouth. All right, so when we talk about masks, there are three types of data sets we look at. We look first at controlled laboratory studies, that these are experimental studies done with different types of masks in different laboratory settings that just inform us on what could potentially happen in the real world when virus spreads. We also look at epidemiological investigations. So smaller groups and outbreaks where we can really follow where infection started and how it spread in a controlled kind of environment. So those are not randomized control studies, but you can do a comparison with two groups. So we'll look at some of those. And then we can look at population level community studies. So this is what happens when a whole group implements a strategy like wearing a mask. So I have three examples of research here. This first one is just more lab research on the different types of masks. If you can read the chart, I know it's hard to read, but the blue columns that are very high, basically they're showing, this chart shows that that N95 respirator contains droplet particles the best. Obviously, we know that. And then the little green one on the side is a face shield. So the bottom line of the chart is the size of droplet particles and how much the mask kept inside. So this is laboratory research, of course, that shows that. Of course, an N95 is most protective, but the cloth mask, the gaiter, and a surgical mask also contained larger droplets and some of the smaller droplets, not all of them. We also have research that, to the next one, sorry. Oh. Gerald, I think you might have gotten an old presentation. Oh man, I have some additional slides. So if that's the one you got, I'm very sorry, I sent you the wrong one. I'll have to, I didn't even print it. Man. Unfortunately, I had many additional slides, so I will email those to you. I'll do my best to summarize off the top of my head. So the next group of studies are epidemiologic studies. So we know there's some smaller examples that happened early in the pandemic. A group of folks on a naval ship where some were wearing masks and some were not. It showed 70% benefit of not becoming infected with COVID-19 in that controlled environment. We also, off the top of my head, there was lots of examples, like there was a hairdresser who had seen 130 or so clients both wearing masks. They were positive for COVID-19, very close contact for multiple hours, and no one became infected. We also saw a study in Thailand where people were going out into the community, and there was a comparison group, and the mask showed a benefit of 70% benefit to protecting infection from COVID-19. So recently, in the last 2 weeks, I'm sure we'll have some folks share, we did have a control trial that was done in Denmark. And this control trial had two groups. One was told to wear a mask in the community and social distance. The other group was told to not wear a mask, but to still social distance. The group that wore a mask, I think it was 1.8% of them became infected with COVID-19. The group that did not wear a mask, 2.1% became infected from COVID-19. So this study, it was looking for a statistically significant benefit to the wearer of the mask, and it did not show that. So that's an important piece of evidence that we need to keep in our minds and in our scientific consensus that when you are in a community that does not have masks commonly worn, the benefit to the wearer, hey, thank you. This is my husband, just to give me a reminder. The benefit to the wearer is minimized. What we can see, even though, I'm gonna skip back here. I apologize for my slides being incomplete. That when two parties are wearing masks, that there is, the benefit of the mask is controlling the source. So that particular study showed when you are wearing a mask and everyone else around you, like might happen here in Enid, you are not as protected as if both parties have the mask on. So I'm gonna reference here.
And I want to hit a point there a little bit harder because I've seen that one thrown out a lot. That was not studying the effect of a mask on community spread. That was based on mask as a personal protection tool.
Yes.
But we're not talking about mask as a personal protection tool. We're talking about masks as a method to limit community spread in general.
Yes.
Is that accurate?
Yes, we do have other research that supports some benefit to the wearer. That particular control trial did not demonstrate a statistically significant benefit to the person wearing the mask. So in addition to that, I'm sorry, I really wish my slides worked. We use large population level studies where a jurisdiction, either a nationwide government, a city government, a state government, implements a policy directive to wear a mask, we see a reduction in new cases per day. So that's what we're looking for here. A lot of people will say cases are still occurring in places with mask mandates. Yes, they will. We know that when you go to a restaurant and you take your mask off, you can still become infected, you can still spread the virus. We know that in small group settings where people aren't wearing masks, you're still going to have transmission. So how I see this is we've been in a marathon and we're all racing with other communities. And other communities got a little bit of a head start. If they implemented a mask mandate earlier, you see a reduction in the rate of spread. So they still have spread, but it's slower. So we have the opportunity to catch up, is how I see it. So just I have some good graphs that I can email you, which I'm sure you get a million emails, but the state of Arizona implemented mask mandate in June 17th. They saw, they were seeing a large spike in new cases per day. 2 weeks later, they also implemented social distancing, but the drop in new cases per day happened right after that policy was passed. So if you look at a curve this way, the opportunity for the closures and the restrictions to have caused a reduction at first, the timing would not have been possible. We believe that the mask policy helped start the reduction in new cases per day. And so their cases continue to fall until September. They're seeing some uptick now as well.
Can you just talk to us a little bit about that comparison in Oklahoma? Because I know the state epidemiologist report does give us some comparison in that data. What increase in infection rate have communities with mandates for a few months seen as opposed to Oklahoma communities without mandates?
So we have had, I think the most compelling one first is in Kansas, our neighbors, they have, they basically implemented a statewide mask mandate on July 3rd, but they allowed counties to opt out of it. So what was created there was kind of a comparison between counties that implemented the mask mandate and that didn't at the exact same time. And what they saw in counties in Kansas that implemented a mask mandate, they saw new cases per 100,000 people until August 23rd. They decreased by 6%, and counties that did not have a mask mandate increased by 100%. So in terms of the difference, that's a point in time when everybody implemented at the same time. So that one, to me, shows a direct benefit. Of course, cases are increasing in Kansas, but those that had that head start, they're at a slower decline, a slower incline. I wish you could see what I can see. I don't have time to do that. But here in Oklahoma, our state epidemiologist has putting a report out since about October. And this most recent weeks, we have seen less of a difference. But there has the percent change from August 1st to November 25th in communities with a mask policy in Oklahoma. They have seen an increase, 265% increase. It's still growing. But in cases without a mask mandate, it's 410% increase. So it's that rate of spread. When you have the increase in cases, you are going to see a decrease. The rate of deaths and the rate of hospitalizations coincides with that increase in new cases. So if you have a slower rate of spread, you're going to see slower deaths and slower hospitalizations. That's the hope.
The Kansas study where they had the two counties that were compared, were they the same population kind of counties? In other words, one's not all rural and the other one's a metropolitan area or something, right?
That is a very important question and is a limitation to the study. It hasn't been peer reviewed, and that is a limitation that some of the communities implementing a mask mandate were more metropolitan urban areas, some that didn't were more rural.
Okay.
What we're seeing in Oklahoma is our cases, we started way behind the metro areas and the larger cities. So now they're having other factors come into play, like the holidays, like the schools reopening, and so they're still seeing cases spread. But that ability to correlate the time frame was a really big benefit to that study.
And I think, George, it wasn't one county as compared to another county. It was all counties in Kansas dumped into two buckets.
Okay.
So all the counties with mandates that all started at the same time, and all the counties without mandates that didn't adopt at the same time. So it wasn't just one, it was two buckets of counties, which is how Oklahoma's epidemiology report has also been looking at our data. And that's that growth of 200 and some odd percent or growth of 400 and some odd percent. That's over twice as fast a rate of increase. And
we
that's
saw
the
very
same,
dramatic
the same comparison.
difference.
It's not one county to another, it's all the no mask counties in one bucket, all the mask counties in another bucket. Despite the mask counties being a higher population density in general, which does correlate to more community spread because people are closer together.
There were also several studies of comparing states, and we can show that before mandates and after mandates, there was a decline in the rate of new cases. So sorry you can't see the graphs that I have. But basically, we know that cloth masks offer source prevention, that source control, that they contain droplet particles, and they prevent some of the virus from being transmitted. And we know that having a policy makes it normal. I am also a small business owner, like I've said before, and my hope is there are many people tonight that, we have different opinions on the policy, but I hope that there's, just by making it more normal, we just need more people to do it. We need more people. And the more people that, that wear a mask when they're in close contact, we will see a slower rate of spread.
And
So-
then can you connect one more dot there, just so we're very clear? Fewer infections mean fewer deaths. I mean, there's a tight correlation between the infection rate and the death rate. Is that correct?
We see different case fatalities in communities for different reasons, but more or less we are all about 1% in Oklahoma die from COVID-19, and anywhere from 4 to 8% are hospitalized. So as long as we continue to see new cases, we will see 1% die and 4 to 8% be hospitalized.
And so by decreasing the infections, we see fewer deaths.
Yes, we will continue to see cases spread, but if we have that many active cases, we have the potential for more people to become infected.
My question to you is there any data that shows a timeline between reoccurrence in a case if a person's infected? Is there a duration of time that they can't be infected? Again, is it like months or weeks, or can they get it back to back? Or
We have a few occurrences where people have tested positive for COVID-19 a second time. They have been very few and far between. So the general recommendation is after you test positive for COVID-19, as long as you don't have symptoms, we think you have some protective benefit. We're going with about 3 months at this point because we haven't had enough time to see what happens long term, but 3 months you have some protective benefit. So when we talk about herd immunity, that's we love herd immunity in public health. That's what we do. And my hope and my good news is that we do have vaccine coming very soon. We have the Pfizer vaccine is one of the first vaccines to be approved, and that is going to be disseminated to frontline healthcare workers in the next few weeks. And so we believe that when more people do become immune, that we will see less spread. That's what herd immunity is. What we don't see in COVID-19, we don't know if there's a durable immunity, meaning if you get infected, that you will stay immune for a long time, or that you will, we do have cases where people have become reinfected. So we can't say once you become infected, you are now not going to have to quarantine or isolate and those things. So we hope that the vaccine will also be a strategy that will reduce the spread in our communities. So,
am I correct that herd immunity is not something like we get 15% of people vaccinated? It's like on the order of 70% of the given population vaccinated or otherwise immune if it does have a lasting immunity that requires that higher threshold. It's not a small thing.
yes, we don't have an exact number, but it's somewhere between 60 to even 80%, depending on the virus. Some viruses require even more people to be vaccinated before a disease won't spread, like we see with the mumps and measles. They're very contagious.
I've got several questions I'd like to ask, if that's okay, down on this end. You said a while ago that Garfield County has a very high rate of obesity, diabetes. You rattled off several things, right? Would we not then assume that our COVID rate's going to be higher as a result of having so many unhealthy people? Probably.
I think that when it comes to severe illness, then we would see potentially more severe illness if those people with those comorbidities become infected. It doesn't necessarily correlate with the number of cases we have.
How many of the 37 deaths had no underlying issues?
It has been documented that at least 70% of deaths nationwide have a comorbidity in that list.
No, of these 37, I was just curious.
37. So death data in Oklahoma and everywhere is very protected. So I actually don't have the details on every single case. We can see statewide though. So I can pull up the epidemiology report for the week And we're pretty much in line with the country.
Because I've
somewhere in the
talked to
60%.
several people that are in that profession. They're saying 100% had underlying issues. Matter of fact, I was told just the other day from one of our officials that gets a ME report, had a 50-year-old that passed away. Obese,
David, you got to get closer to the mic. You're not.
diabetes, 100% renal failure, on and on and on. I mean, the whole list
Yes.
died of COVID.
Yes. Yes.
So
What we would say is, I know a lot of people are talking about that. People can live a long time with obesity. People live a long time with diabetes. People can manage their heart disease. So yes, there are comorbidities that put you at a higher risk.
And of all those positive cases, 600 and whatever it was, how many of those folks do you think are asymptomatic?
We think anywhere from 20 to 40% of people might not show symptoms or severe symptoms. They may be asymptomatic. About 20%, somewhere in there, are
You think
asymptomatic,
or you
and
know?
40%.
I mean, is that data or is that just what you?
Yeah. Oh, yeah. I have a graph. It's just not on the screen. Yes. We had.
And then while you're looking that up, I was also wondering, you said something a while ago that the droplets and that the mask will stop that. Do you contaminate that mask every time you touch it
Yes.
with your hands?
Yes. And there is
So
no.
like when we cough into our hands or I rub my eyes and I touch a door handle, I've contaminated that for everyone, like everyone that came into this room or
Absolutely.
Walmart or any of those places, right?
We do see cases of fomite transmission, which means droplets that are on surfaces. So we still recommend washing your hands. We still recommend disinfection of surfaces. Those are absolutely recommended.
I was told today by a doctor that they would like to see people not wear latex gloves because they are not washing their hands then. Right? And they're touching the money and they're handing it back to us and our credit cards and a bag of food and
We would, yes, we
Right?
have restaurant inspectors at the health department, and
Yeah.
that is something they talk to restaurants about too, that you have to wash your hands either way, even if you wear gloves,
And then last question.
and change your gloves.
Are you aware, and I'm sure you are, that any business in town can require their patrons, their people that come in, to wear a mask, right?
Absolutely. I own a business that requires employees to wear masks, but because we're customer service based, it's very difficult for an employee that works hourly to.
So that was my next
require the
question. Knowing that you
customer-
do own businesses here in town, why do you not require your folks to wear a mask when they come in, your patrons?
Yes,
I
absolutely.
mean, I would think you would lead the way on that.
We've had extensive discussions, and actually some of our partners wanted to require customers.
I know, but you
What
chose
ends up
not to, right?
What ends
Better
up
answer the
happening
question.
is that the wonderful people we employ that make an hourly wage have to speak to a customer that they want to serve, they want to love, they want to be
No,
happy.
but you're here tonight.
David, you got to let her answer the question.
No. I want to ask a question.
You did. Let her finish and
Sat here
ask it another one.
once and listen to Ben go on and on and on and on.
David, I'm not telling
I'm
you
gonna
can't.
ask a question.
I'm not telling you can't ask a question, but she hasn't even finished answering the
She
question.
did. She said that her employees want to be able to help that patron.
She didn't answer the question, David. She didn't finish the answer.
Go ahead.
Stop.
Go right ahead.
and Let her answer.
And I'm here.
Ben, don't tell me what to do, okay? Don't. Not going to do it.
I don't.
Bullied us for
People
months.
right. I know, and I've been right for months. So
So
let her
put
answer.
your hand down, whatever. Not going to bully anybody.
Let her answer.
Tired of it. Answer it. Yeah, I'm good.
I'm here, representing the health department and happy to look up data. But if I put on the hat of a business owner, it is difficult for me to require someone that doesn't have a lot of, they want to serve a customer, to ask them to do something that is not friendly, that is would protect them and would protect their health. So having the support of the community, we ask people to wear a mask, but we don't feel like it's customer service friendly as a business to require it. And that's something that we've debated a lot. And my business partners, they really wanted to. So it's something that we think is it would help protect our employees. We know several businesses have had to quarantine employees, and that makes them lose sales and makes them lose profits. And, you know, we think if our customers wore a mask, it would keep our employees from having to miss work, and it would keep them from having to become ill themselves. So we think the support of the community is really important. But as a customer service business, it's very difficult to require that of your customer.
Well, I think I see it. I think I can see it two ways. I can see it as a competitive advantage. If your customers understand that you're so concerned about their health that you're going to require other customers to come in to guard their health by taking precautions.
Yes, absolutely.
So it could be, you know, you hate to send them down to the next shop down the street because they don't have to wear a mask there. But in fact, it can be spun the other way around and say, don't you feel much safer here? We're looking out for you. I mean, I don't know.
Yeah.
And let me add, I mean, I've heard this from business owners, and I've heard this several times. Put a little more bluntly, my minimum wage employees, my low wage employees, my hourly employees don't feel safe confronting a belligerent jerk who won't wear a mask. Lots of people have simply been belligerent, and it's really hard if you're a 19-year-old kid working as a cashier somewhere to be put in the place of confronting people who can be jerks. The other part of it is I had one business owner tell me, hey, listen, can you guys just pass this so I can point to the city as the bad guy? Because I don't feel safe, my employees aren't safe, my customers aren't safe, but I'm afraid I'm going to lose my business to somebody who doesn't want to do it. I want them to do it, but it's so much easier if I could just point to the city and say, hey, man, the city's the bad guy. Sorry, we all got to do it that way. And that it is a kindness, it is a benefit to small business owners and hourly wage employees to take some pressure off them, because I don't know if I was 19, 20 years old that I would have felt comfortable as a barista at the Coffee Bean where I worked when I was 17, telling somebody, you know, who was otherwise kind of aggressive, hey, you got to do that. It's not so easy. I don't think it'd be easy now at 34.
I think as a representative of the health department, I think the hospitals have some good information to share, and I think some other business owners could give their perspectives as well, because I'm here to share data. And I want to make sure that Jan Fox, if she has any responses to questions as well,
Yeah.
that she has.
David, did you finish? Did you have any other questions?
I think that's it. I just want to clarify that you don't want your 19-year-old employees having to confront someone that comes in and asks them to put on a mask, even though even now today, if they didn't put one on, you could call the police, they would come out and either make that person leave or put on a mask, right? I mean, you could do that today. And that's exactly
Some of our
what we're
employees
about to vote on.
Yeah. I want to go
Right?
back to.
I mean, it seems to me like you're trying to have it both ways here.
I want to go back to just my perspective on the transmission of fomites
Maggie.
and the other.
Maggie, can we hear from the other speakers? You've had
Absolutely.
45 minutes now.
I have not my choice. Dan,
You've
do you
had
have
45 minutes, ma'am.
any- Okay, I
Saying
answered
yes,
questions.
Jerry. Quit being so She's saying yes.
Ben, it's okay.
Okay.
Yes, I'm looking forward to hearing from the hospitals as well. Thank you so much for your time
Okay.
and for listening.
Thanks, Maggie. Appreciate it. Next up, can I ask, is Dr. Bartoloso in?
We have Finney or Krista on Zoom, or Gerald, do you know?
Yeah, we'll get them too.
Okay, cool.
This is Finney. I'm here. If Dr. Bartolozzi isn't here.
Yeah, he's here.
Okay.
And Vinny, you're up next.
Good evening, ladies and gentlemen.
A little closer to the mic.
Good evening, ladies
Thank
and
you.
gentlemen.
Thank
There
you.
we go. I just wanted to kind of give you a little bit of education about the coronavirus itself, because that seems to be one thing that's lacking not only locally, but nationally. And this is from Dr. Fauci, who wrote the chapters in Harrison's textbook of internal medicine, which is the Bible of internal medicine.
Doc, would you speak up just a little bit? I'm so sorry. I'm just hard of hearing.
Anyway, the Bible of Internal Medicine is the Harrisons. Dr. Fauci is the signature of the infectious disease portion of that textbook. The coronavirus is a simple virus. It's an RNA virus, single strand. It's a member of the enterovirus family. Of course, my pager would go off. Oh, it's an ER. Hold on. If somebody else I had to call.
Yeah, okay. Finney, if you're ready, go ahead.
Right, can you hear me?
Yes, we can.
Okay, thank you. I'll try and make this quick. So most of my comments relate to coronavirus from a hospitalization standpoint. And so a little bit different flavor from what Maggie was presenting. But my numbers, we didn't coordinate our numbers or anything, but my numbers in Oklahoma, you have a 0.9% chance, a 0.9% mortality chance. If you are COVID positive, there's a 6.3% chance you're so sick that you need to be in the hospital. That number jumps up to 8% if you're in your 50s and 19% if you're over 80. And so these are numbers from research studies. Where we run into issues is the type of care these patients need if they come into the hospital. About 35% of patients who need hospitalization need an ICU. They need an ICU bed. That's our most severe level of care. And if you have an ICU stay, the current mortality across the state is 28%. So that means if you come into the hospital COVID positive, at any point in your stay, you're in the ICU, the mortality rate is 28%. It's lower in Enid, it's about 19 to 20%, but still, these are the sickest of the sick. If you're hospitalized and you don't have an ICU stay, your mortality is about 3%. Blended, we see about a 13% mortality rate for hospitalized patients. So this is if you're sick enough to come into the hospital. Where I think the discussion starts to get off a little bit is that lots of people are focusing on mortality and that not enough people are dying for for us to take significant action. From a hospital standpoint, the hospitalization rate is much more important to us because whether or not you pass away or whether you stay in the hospital and get better, you still take up resources that are needed. And so that's where we see this bed crunch come in, particularly related to ICU beds. And so that's why we'd really like to see help in reducing the overall hospitalization rate. And the way you do that is through the overall reduction of infection rates. Transmission of the virus, it's primarily a droplet-based disease. That means if you sneeze, cough, the virus spreads. You reduce that spread through the use of surgical masks and secondarily cloth masks. This is the first place where we start to see some confusion around mask efficacy. If you take a jar and fill it up with virus, put a surgical mask over it, flip it over, that virus is going to spill out. The surgical mask is not going to stop the virus itself. And that's where the confusion comes in. What the surgical mask actually stops is the droplets that carry the virus. And that's why the surgical masks are okay to use for a droplet-based disease. Things like the flu, COVID, those are droplet-based diseases. The next level up is an aerosol disease, an aerosol-based disease. That's where you have to wear an N95 that's fitted. And why this is confusing is because in many of our industrial work, we are protecting ourselves against aerosols. And so that's why, whether or not you have a beard, whether or not that mask fits is really important. So there is a fecal oral transmission method as well. So basically if someone gets poop on their hand and they're COVID positive and then they rub their nose or transmit that, this was discovered in China. The root cause was poor wastewater management and in buildings, the vent pipes not being done right. So primarily not an issue in the United States for that. If you know a plumber, give them a hug. Masking overall is supported by many of the societies that are kind of the parent societies for many specialties for doctors. And so why that's important is, let's say you have a physician who is going through a lawsuit. One of the first questions we ask is, what does your family medicine or internal medicine or cardiology society say about how you treat this disease. And I have a list, all of the societies of the physicians that take care of COVID patients support masking to some degree. I spent 2 hours last night trying to prove myself wrong and looking for studies that did not support masking, intentionally going out and trying to find studies that don't support masking. And I found some trends. This Danish study, a lot of people are referring to now, the first line of the conclusion says that it does not recommend wearing surgical masks because they don't reduce COVID infection rate amongst wearers. That's the first part of the conclusion. But in that same sentence is the rest of it by more than 50%, and later on it says the data were compatible with lesser degrees of self-protection. And so if you take the first part as being accurate, that it doesn't protect, you also have to look at the second part. And this is an issue in the way the study was designed. Really, the study was inconclusive as it relates to overall mask protection, because that's not what the study was looking at. I looked at some things related to other websites. The Center for Infectious Disease Research and Policy had a great headline that said, "Data do not back cloth masks to limit COVID-19." But when you read the study, it says it doesn't protect you from aerosols. And we agree, a cloth mask or general masking in the community is not going to protect you from aerosols. The last study I'd like to point out is probably the most scientific study related to whether cloth masks are effective or not. And it was done in 2015, so well before all this COVID stuff. And the conclusion of the study has been cited by a lot of people as a reason why cloth masks or general masking is not beneficial. And it said the rates of all infection outcomes were highest in the cloth mask arm, with the rate of ILI, that's influenza-like illness, statistically significantly higher in the cloth mask arm. So people take that quote and say, that says people who wear cloth masks get sick more often. When you go through this study, one, it was funded by 3M, who makes N95 masks. The second thing is the control arm. The standard practice was people who wore masks in general. So there was no group of people they looked at that didn't wear masks. And the primary virus that was transmitted through the mask was rhinovirus, which is an aerosol-based disease, which the cloth mask wouldn't keep from spreading anyway. In fact, the authors had to release a follow-up in relation to this article because it got picked up during COVID times, was being misrepresented. Herd immunity is something that Maggie touched upon. Intermountain Healthcare, major top healthcare system in the country, released some information that right now they think if you get COVID naturally, your immunity only lasts 9 months, not infinitely like we originally thought. So in order to have herd immunity, 70% of the population would have to be reinfected every 9 months. Right now, for perspective, we estimate about 10% of the population is infected. So one, we'd have to infect 60% of more people, and we'd have to do that every 9 months. So according to this study, they don't think herd immunity is possible in any way within the US. Sweden has been mentioned. Early indications, for those that don't know, Sweden took a very laissez-faire approach, no restrictions, let people kind of do what they want. And early on, it was really promising. Lots of people were going, man, we should do that. But there was a high moral cost initially with the Swedish approach. The way they kept hospitals from being overwhelmed is that if you were over the age of 80, you didn't get to go to a hospital. And so that is not ethically or morally in line with how we do healthcare in the United States. And secondly, now Sweden is seeing an uptick and has their health minister, who was the architect behind not doing anything, has said there's no way they'll achieve herd immunity without a vaccine, which luckily we're close to a vaccine. They've got about 6,500 people who have passed away in Sweden. Our message to the community, if you're willing to do anything to reduce the spread, we would appreciate it to help reduce the hospitalization rate. But if you're sick in the community, we want you to know that we'll take care of you. Come to our ERs. We will find a place for you if we have to. We'll send you home and monitor you if we have to. We don't want you to fear coming to the hospital or think we are unable to take care of you. It may not look like the way we've traditionally taken care of you, but you're in great hands with Integris and St. Mary's both in your community for all of Northwest Oklahoma. We're a referral center, and again, we're here for you. Happy to answer any questions from the group.
Can you talk to us, Finney, a little bit about what the capacity is of Integris? I keep seeing that we're on emergency divert, which is a term I kind of only barely understand. I know we're sending people all over, that we can't send people where we used to, and that conditions in your entire hospital group are a little bit crunched. Talk to us a little bit about what that means in practice here in Enid.
Sure. So COVID-19 patients need a very specific type of room. It's called a negative pressure room. And typically you only have maybe 3 or 4 of those in a hospital. The reason goes back to those aerosols. They're the ones that spread a far distance, droplets, maybe about 6 feet. Aerosols can hang in the air for an hour. And so that has caused a significant issue. That's where you have to fully garb up. It takes a lot of people resources. We have had to make multiple makeshift negative pressure rooms to take care of these patients. These are rooms that if we were in a normal mode of operation and the Joint Commission came in, I mean, they would tear us apart for having rooms like that. Are they clinically safe? Absolutely. Are they the way you normally do it? No. From a capacity standpoint, our ICU has basically been full for months. We have trouble finding beds for patients within the state. We know of patients that have had to go to Kansas and Arkansas from Enid because there aren't beds in Oklahoma. And again, this comes in waves. So, we've got some bed capacity today. That doesn't mean an hour from now, we'll still have that same bed capacity. It's been hugely taxing on the staff. We're facing burnout, tears. We can't pay staff enough to come in and take additional shifts. This last couple weeks was probably our highest rate. We're concerned about activities during Thanksgiving and what that might mean a week and a half from now, and how we would cope both from a staffing standpoint and just an overall availability standpoint. And does that answer your question? I hope I didn't ramble too long.
No, I just want to, just dumb it down a little bit. Is that impacting other care? If I am in a car accident and need emergency surgery on my leg, do you have somewhere to take me?
Yeah, so if you were in a car accident and needed emergency surgery, we would find an ER room for you. We would put you in surgery, and you may, depending on the day and even the hour, you may not have a bed on the floor. We might hold you in surgery indefinitely until we could find a space. We have held patients in our emergency department for 3 days looking for space. And that's why I go back to, if you need care, we'll get it for you. It just may not look the way that it has in the past. It may not be pretty.
I've got a question. Is it Mr. Matthews or Dr. Matthews?
It's Mr.
Mr. Okay.
You can call me Finney though.
Okay. All right. Are you still doing elective surgeries right now out at the hospital?
We are.
How much of your staff is dedicated to the elective side versus the COVID side?
That's a hard number to give you, and I'll tell you why. The staff that take care of elective surgeries, we don't have a dedicated staff that takes care of elective surgeries. We have a staff that takes care of surgeries. That staff has a different competency than the people who take care of COVID patients on the floor. That being said, part of our surge plan is to put COVID patients in the surgery area and essentially shut patients down should it come to that. Shut elective surgeries and essentially non-emergent surgeries down if it comes to that.
When would you do that? At what point?
That's a hard point to get, hard number to give you, because it really depends on the level of care needed by the patients on the floor at that time. There are certain patients who need a 1-to-1 ratio. There are certain times where we can go 1 to 4. So while we have philosophically what that would look like, we haven't set a hard number.
Are there any coronavirus patients being transferred in from Oklahoma City to our hospital here?
Yeah, I'm glad you brought that up, because one of the things we've heard in the community is concern that we're taking patients from other communities at the expense of Enid or Northwest Oklahoma. And what we see in general is that for patients that come into our healthcare system in Northwest Oklahoma, we're essentially shipping the same number out. And you may go, well, why would you ever do that? It really depends on what bed is available and at what time. So if a bed is available in Oklahoma City now, and I don't know that I have one coming up available here, I'll ship that patient to Oklahoma City. When a bed opens up here, if I don't have someone to put in it locally, we may get a patient from Oklahoma City.
When we have a death out there, who has the discretion to determine how the death certificate is filled out? Is that the doctor?
It is the physician.
And only the doctor?
Correct.
Okay. And I was talking to a physician today in Colorado, and about the same thing. They're dealing with a lot of the same things we are. He told me that when there is a COVID death, that there are federal dollars, additional dollars that come to the hospital. Is that correct?
Kind of. I wouldn't put it in that context. So whenever patients have an illness, they're put into a DRG, diagnostic related group, and there is a specific DRG for COVID patients. That doesn't necessarily mean they're extra dollars. So yeah, I don't want anyone to think that we're coding patients as COVID deaths for the purpose of getting additional reimbursement.
Okay, but I heard you say, yes, there are additional dollars. Did I not?
No, there are dollars associated with that DRG, just like there are dollars associated with every other DRG.
Okay, so someone comes in and dies of pneumonia, it would be the exact same dollars coming to the hospital as COVID?
Not necessarily, because if you come in and die with pneumonia, there are different levels of care that you might need that change the DRG. There is a COVID DRG, there is a pneumonia DRG, and within that DRG, there are differences based on the level of care you received.
Okay, all right. I know this has been taxing on your staff, and we appreciate them so much. I know a lot of the nurses and docs. We hear a lot about nursing shortages. How long have we had a nursing shortage in Oklahoma? Just curious.
We have had Oklahoma, I think 46th in the country related to having a nursing shortage. So a nursing shortage in general is not a new phenomenon for the healthcare industry.
Right. Okay. That's what I thought. Thank you.
Okay. Thanks, Vinny.
Anytime.
Dr. Bartolozzi, if you had to get interrupted, so I wanted you to have a chance to finish your remarks.
Perhaps if I could just answer questions. I've got a little bit of limited time here, so if you have maybe some questions directed that I could help you with in the care, because I am involved. I'm an interventional cardiologist. I'm the director of cardiology at St. Mary's. And I have to deal with the complications of the COVID infection, which is inflammatory, not infectious. And I'm involved with some of the patients at their end of life. So I can answer questions if there's anything that you need to know.
I just have a question about how lasting it is. I know we have this number where we show a recovered number, and I think I meant to ask Maggie, but ran out of time, but I think that recovered number is not so much a function of whether you're back at where you were. It's kind of a, time after infection. But I keep hearing about people who are dealing with side effects with especially related to blood clots and small vessels, and the side effect from that long after. What kind of time period are you seeing for those kind of?
We can see it. I'm seeing it out to maybe 4 weeks, 6 weeks. You have to keep in mind that this is an inflammatory reaction. It is a cytokine storm. It's a result of an immune system response, which is exuberant. and it causes a massive release of chemicals, neurohumoral chemicals released from the white blood cells, the different classes of white blood cells that are involved with the immune response to infection. What we're dealing with, this is an enterovirus, which means it causes infection in the gut. As such, it's excreted in the stool, fecal-oral transmission. Like all the rest of enteroviruses, same family of the flu. Flu's in the same family as the coronavirus. So what we deal with, you get the infection, the initial stuff, they get the GI stuff, the diarrhea, the nausea, vomit, don't feel well, that's the initial infection. Then the immune system responds to the infection. That's where we start to, that's where I come into play a lot. The patients come into the hospital, they have the chest, they're hypoxic, low oxygen level. They got a chest x-ray, shows typical chest x-ray findings. So we get a CAT scan. CAT scan shows typical peripheral findings of an interstitial pneumonia. We get, inevitably, the ER doctors, as part of everything, they'll get the D-dimer, the CRP, we'll get a troponin, all these markers of inflammation. They're elevated. So what happens is, okay, they call me, Dr. Bart, we got a patient here. They got an elevated troponin. They're coming in, they're COVID positive. They've got pneumonia. They're hypoxic. We got them on a BiPAP. They were initially high flow neb, now, or high flow nasal cannula. Now they're on a BiPAP. You know, are they having an heart attack? So I come in to see the patient, and I do my evaluation. And classically, with these patients, they have what's called a myocarditis. Myocarditis or myopericarditis. That is an inflammation of the pericardial sac and the heart muscle, the myocardium. This is not a direct infection. This is not the COVID virus attacking the structures of the body. It's the inflammatory response as a result of the infection. And once I determine that through my evaluation, usually I put them on, it's a joke around town, I'm the colchicine guy. I'll use colchicine. It knocks the inflammation out. The troponins drop and the patient gets better. And in some cases, I've actually seen them clinically improve on the ventilator. You know, they come off the vent in a couple of days once we start colchicine therapy. You know, you don't hear about that much as you do the hydroxychloroquine and stuff like that. But I've got plenty of support from the OU and Integris guys because I take care of some of their family members, and they're on colchicine or been on for various reasons, and they're happy that their family member is being treated with that. That's aside. So that's the thing. What we deal with is inflammation. You know how we treat this stuff? You know how we treat the inpatients? Anybody told you that stuff? No. Okay. We treat them with high-dose steroids and vitamins. That's what we treat them with. We give them 4 to 6 milligrams of IV dexamethasone 3 or 4 times a day, which is a very potent steroid. And we give them thiamine, vitamin C, vitamin D3, and zinc in high doses, super physiologic doses. But that's how we treat it. There's no magic bullet. The remdesivir, all the studies, and then the latest one a couple of weeks ago in the New England Journal of Medicine was equivocal as far as does remdesivir really do anything. And I can tell you from dealing with the patients, we got an ICU full over there at St. Mary's. They've gone through, there's four of them. Yeah, 46, 48, 50, 56, 53. How many is that? 5 patients that have completed. They've been there for 10 days, working on 2 weeks. They've completed the remdesivir. They've completed the dexamethasone. So what are we doing? We're treating them supportively, tube feeding them and giving them their vitamins and treating any secondary infections that occur because they've been
So am I
intubated.
understanding you to say that they could go home then? They could be treated at home at that point?
No, sir. No, those patients are probably not going to go home.
The ones you were just talking about, that you've given them all the vitamins and they're just
Yeah,
sitting?
they're still intubated and sedated, paralyzed, and ventilated. No,
Okay.
they're
right.
probably not going to go home.
They've done everything they can do.
We have run through the typical treatment for this,
Okay.
which is the remdesivir. The Regeneron, really, unless you give them the first 24, maybe 48 hours, like they did with Trump, it may show some benefit, but beyond that, it's really doesn't do any good. And the study in the New England Journal of Medicine, that was out a couple of weeks ago, it was equivocal as far as does remdesivir work? Not really. I mean, they didn't see any remarkable advantage either way, remdesivir versus no remdesivir.
Are you getting, are we going to have the capacity to do the monoclonal antibody treatment in Enid? And do you see any value in that?
Only if it's early. And the problem is when we see the patients, that's a thing. By the time we see the patients, they've been sick for several days. So they're outside of that window where we're really going to be able to help them with immunotherapies. So my point, and the point here is, it's an my whole thing to bring this home is it's an inflammatory response. It's not a direct infection. That's where everybody gets it wrong. It's not a direct infection. It's inflammation. This is inflammation. The myocarditis is inflammation. Gets better with inflammatory drugs, non-steroidals and colchicine, what I take care of, the myopericarditis and the arrhythmias. That's what kills people too. That's what's killing people. They go home in 4 weeks, they drop dead. They wonder what the heck happened because they weren't diagnosed with the myocarditis. They weren't treated. They went home, developed a cardiomyopathy and an arrhythmia and dropped dead. The inflammation in your venous system, the same thing that causes the pericarditis and stuff, myocarditis, causes inflammation of your blood vessels as well. That's what causes the blood clots to form in the legs and stuff, and then the people. And then, of course, they're more sedentary because they've been, the ones that are really sick, like I'm talking about ICU patients, they go home, they're not well, they sit around, and that, of course, sedentary inactivity, that increases your risk for blood clots, of course. But if you have this underlying inflammation as a result of the infection, then that's caused the problem. And that's what I want to explain about that was the mask. This is inflammation, and the mask does, people cough. The studies from Europe, of course, they don't get much play on this side of the pond. They didn't show much viral load in the aerosols that were expressed when people coughed or sneezed. If there is any virus in the aerosol that is expelled, the viral particles, we're talking microns, man. These viral particles are tiny. They're going to go right through the cloth mask or your paper mask or any type. You want some, an N95 is what we use a lot. I'm going into the COVID rooms. I'm looking down the bridge of my nose, and I'm seeing a gap like this between my cheekbone and the edge of my mask. So, it's not airtight. I go to Walmart and somebody walks behind me and I get dusted. I can smell it. I mean, it's coming right around my mask. So my point is that it's not, contrary to what everybody's saying, it's not that. It's because what we see on the chest x-ray prove to you. These patients come in the hospital, we intubate them. We always send cultures. We check blood cultures, we check sputum cultures, and we check urine cultures. The sputum cultures we get by going down the endotracheal tube with the suction tube and actually pulling the secretions out of the lungs. So these aren't mixed with oral secretions or anything else. They're sterile. They grow nothing. The blood cultures, they're sterile. They grow nothing. The urine cultures, they're sterile. They grow nothing. So, so my point is, they're not coughing. When they cough or they sneeze, they're not blowing out viral particles because, folks, if there was something in here, it would grow on the cultures. So that's why I wanted, hey, Mike, how are you?
Yeah, Don, I'm gonna have to ask some questions here. I love your theory, which
Sorry, I don't
No.
want to interrupt you. Can you just introduce yourself and just
I
let everyone know here? And
I apologize. My name is Mike Pontius. I'm a family physician. The basis of the issue with the mask is to control the spread of the virus. And there is no one on this universe that is going to argue with you, Dr. Bartolozzi, about the inflammatory cascade. But where does the inflammation come from, my friend? Tell me.
Say what? I'm sorry.
let's not get too deep into the weeds because I assure you, I only caught like.
I got it though, and this is the point of contention, because the assertion that he essentially just made is that when the droplets come out, that the virus will not come with it, and you won't spread the virus that way. Am I correct? And that's the assertion that you just made?
Yes.
Okay,
Yes.
because that's counter to anything that I've ever read or from any scientific journal or anything that's been written. So this is the part that I really want to understand, and I'd love if two medical professionals can fight this out, because that blows my mind.
My point would be that in order for the inflammation to happen, there has to be a trigger. It does not happen de novo. It does not happen in isolation or by itself. It has a trigger. John Bartolozzi, you know as well as I do that a viral myocarditis does not start with inflammation. It starts with a virus. You also know as well as I do that a culture in this day and time is for bacterial culture. It is not a viral culture. We have not perfected that technique to where that is readily available. The issue at hand is trying to protect people against the viral trigger. I agree with you 100% that the cascade is secondary to inflammation. There is not one argument that I have with that. What I do have an argument with you is this idea that somehow this virus that pervades this community and is making things worse day upon day is not the trigger. If you can give me data that shows me that it's not the trigger, I'm happy to back down, but
No, I
you're
agree.
not going to convince me
No, the
that
virus.
this inflammation de novo shows up.
No, it's Mike, it's in response to the immune system.
But what
virus.
stimulates the immune system?
Right. As a result of the virus.
Okay.
What do you recommend, Dr. Pontius?
You know, the problem,
I'm asking Dr. Pontius what he recommends. Nope, excuse us. This is for the city council study session. We get to ask the questions. Dr. Pontius, what do you recommend?
I recommend that we mandate masks. It is way beyond time. We are 2 months down the road from when this should have been done. You know, I'm of the personal opinion that all of us are responsible for that. I cannot believe you people are sitting in a room without masks on. This is
excuse us.
This is a
Excuse us. We're going to listen to the doctor, okay?
It's fecal oral.
I can't see patients in a room because I can't distance from them. I've been seeing patients now televideo for 2 weeks because it's not safe.
I've been seeing patients since March in the exam rooms, but I take precautions. So I'm not arguing with you.
I appreciate.
That's how that is.
Are you standing by the contention that the virus is not spread by droplets that come out of the mouth, the nose, Is that your contention? Are you standing by that right now?
Who's that?
That's me right here. I'm right here.
Oh, yeah.
Is that your contention? Is that what you're standing by right now, that the virus is not spread?
Based on those studies from Europe that showed there wasn't that much viral load in the aerosols.
So not much, but it can be spread through the the droplets that come out of your nose.
You have to have a certain amount of the viral particles, and they're small. They're microns. They're
Gotcha.
going to go through the mask.
Gotcha.
And-
Mass effective for
and how's
droplets.
the mask going to work walking outside when you got 20, 30 mile an hour winds and the air is going right around? My contention, I mean, a mask, a true mask that's going to prevent something like this would be a CBN.
Okay.
Chemical, biological, nuclear
Gotcha.
with the.
So
with the-
what you're saying
the
is
cans.
that what you're saying is that the surgical mask, even the N95s, that they're essentially worthless in keeping the virus from being transmitted from an individual out into the atmosphere.
It's not aerosol, it's fecal oral.
Okay, but
Again, transmitted by bodily fluids from inside the body, that a mask, whether it be the surgical mask, the N95, a gaiter, or whatever it may be, that they're essentially useless because you say that the virus is so small that even in a droplet, it's not going to make it past.
It's going to go
make it
through,
past.
the virus will go through the
So
weave,
the masks are essentially useless, is what you're saying.
pretty much.
is the okay.
For the prevention.
Folks, come
Now,
on, we got finite time here. Is
No,
it true? I'm gonna ask Dr. Pontius a question. I'm gonna ask you a question.
Okay.
Is it true, Dr. Pontius, that virus is suspended in droplets?
Yes,
Is it true, Dr. Bartoloni, that the cloth mask has some effect on droplets?
That it has some effect on droplets.
I'm not asking if it's perfect. I'm not asking if it's bulletproof.
Yes,
We
it'll
saw a graph from Maggie that showed N95s or this useful against droplet sizes greater than a given micron level, and that cloth masks or single layer cloth masks are this effective and double layer cloth masks are this. I'm not saying it's perfect, but for larger droplet size expulsion, is it true that cloth masks stop larger droplet sizes?
You have to define what's a larger droplet.
Okay. Is it true that cloth masks have some efficacy for some degree of droplet protection?
From the virus, the
No,
part.
but I'm asking about droplets.
Well, that's why we use masks and sterile
Okay, but
procedures and stuff to
Right,
prevent.
and
me
I
spitting
ask
on
it that
people.
way because the overwhelming science has indicated that the primary mode of transmission for COVID-19 is via virus suspended in droplets. And I don't think that we're going to get productive conversation. I appreciate the input you've had tonight. I know we do have finite time, and I just want to give a little more time to Dr. Pontius. You've had 10, 15 minutes. I appreciate your input. I would like to ask Dr. Pontius a couple questions if that's okay.
Oh, yeah,
Do we
absolutely.
have any other questions for Dr. Pontius? Yeah.
Looking at it from an economic standpoint, I have a family member very close and dear to me that went through the COVID virus. And when they received their medical bill for 5 days, it was over $50,000. My question is, do we turn away anyone that's uninsured? That's my first question. Does anyone uninsured get turned away?
No, sir.
Okay. Second question to that is, how long do we think our economic system is going to be able to work and stay functionable if we have doctors and nurses and everyone in the medical field being overworked? And I'm looking at it from a point of our insurance companies. You know, you have people that are in the hospitals that don't have insurance. They're not able to pay for this. If it gets out of control, how will individuals as yourself, professionals, continue to be able to survive and make money to live? You know, because we can't just live by donating funds and donating services. You're a doctor, you get paid for your profession to help save lives. If the federal government doesn't kick in and help us, what do? what do you foresee in the future as far as the economic impact that this might have on our community if we don't attempt to do something that can help us? You know, because we're still studying data, we're still studying statistics. And the reason why I'm saying this is because everyone isn't impacted the same way. And I want to say this, and you can answer it. The person that this happened to that's in my family, I was around that individual every day. I never did get infected, but the individual did. So we don't know. You know, we really don't know. We're still learning. And in the process, economically, because I've received a lot of emails, a lot of text messages, a lot of phone calls from business owners, just as myself in this community, who are concerned about, you know, the mask mandate affecting our businesses. But on the flip side of that, a catch-22, if we don't do something about it, our insurance companies and our medical facilities may run out of money if we don't have any help from our federal government. That's my concern. So what do we do as a community, as a nation, to help prevent this from happening to where we don't have an economic depression?
Is that question to me?
Yes, sir. Yeah. To either doctor.
I'm not sure that's a doctor question.
Yeah, that may be a bigger question.
Hospital administrator kind of question.
Have you all ever discussed that? I mean,
Wash your hands, keep them away from your, so I tell my patients, wash your hands, keep your hands clean. I wear gloves in the exam rooms. I change gloves between patients. And I'm so far, so good. I tell patients, wash your hands, keep them away from your face. Don't rub your eyes, pick your nose, stick your fingers, lick your fingers to turn pages and stuff like that. And that's simple. That's easy. And that's the most important. I can give you anecdotal stuff. We don't have time to go through it myself, but you know, I've been, Giovanni, my youngest, got COVID infection first part of October, and naturally, Sandy thought it was my fault because I've been helping to take care of COVID patients, and she tested negative, and so did I, thank God. So I didn't have to take any time off. So we in the house, but you know, Giovanni's got his bedroom upstairs and his own we don't share the facilities. And, you know, like I said, I have to keep my hands clean because if I bring something home, I'm going to be sleeping in the carriage house because Sandy doesn't deal with the patients. I do. If she gets sick, she blames me. If somebody else in the house gets sick. Plus, I have a son who's in undergraduate pilot training out at the base. And we have to, and, you know, in order for him to be able, LT likes to come home for supper every night. So we really have to be careful about about everything so that Luciano doesn't turn positive, because then he'll be quarantined and he'll be taken out of his flights for the 2 weeks. So we keep our hands clean. I got Purell and Germ-X, and soap and water. Soap and water is better than Purell and Germ-X for keeping your hands clean. And you know, we've been fine. So that's what I would recommend as a cheap alternative to all the other things. I think if you want to wear a mask, I think should be a matter of personal preference, choice. Mandating people to wear masks, I don't think, because I sit in my office, I'm sure, and Dr. Pontius can I'm sure would corroborate this. We sit there, we see patients, I see them, they got their masks on, wear their hands all over their face the whole time. So you're touching us. So Dr. Pontius, I'm sure will agree with me, it's fecal oral transmission. Even Finney said that, which is what I've been saying all along. People are not cleaning their hands after they use the bathroom. They go out and touch surfaces. You go out and touch those same surfaces, whether or not you have gloves on or not, and then you rub your eyes and you say, "Oh, I don't do that stuff." But just have your spouse or whoever watch you for a little bit and see how long it is before you're rubbing your eyes or you're reading and you flip a page in your book or something like that. I mean, your hands are going to be on your face, and so you're going to inoculate yourself with the virus. So again, I think the most important thing, like I tell patients, is wash your hands, keep them away from your face, and especially if you use the restroom, for God's sake, or if you sneeze or whatever, wash your hands. You know, I mean, don't just go on down or go like this, okay, and then go out and shake hands or touch other surfaces. So
Hey,
anyway.
Doctor.
Thank you. George, can we, I really, I know we're bumped to good time. Really want to try to get a little bit of Dr. Pontius' time in. Can we squeeze it in real quick?
I do have one additional question. Do you feel like your hospital's overrun right now?
Yeah, we have a lot of sick
Getting
patients
close.
in there. Yes, sir.
Okay.
How much time do you want, Ben?
I just want to ask Dr. Pontius, because Dr. Pontius has been seeing a lot of folks, he's been practicing here.
Thank you, doctor.
Thank you. I want to,
Yeah, if you have a specific question, go ahead, and then we'll take a quick 10-minute break, but.
Dr. Pont, thank you for bearing through all that. What are you seeing, and what can we do? You see people, you've been practicing here an awful long time. What can we do?
Well, the issue is what you just heard was an alternative story of what I think the 9 out of 10 doctors, let's do it that way, would say. This is a disease that is disseminated from a respiratory approach. Am I going to sit here and tell you that it's not in the gut? No. 30% of the presentation is with GI symptoms. But this is a respiratory illness. Coronaviruses have always been a respiratory illness. It makes absolutely no sense to me to live in a community that is not trying to mitigate and decrease the spread of this illness. You know, of the 38 people, 37 people that have died, I'm personally responsible for 3 of those deaths. Now, I tell you that I'm responsible. I've done everything I can to take care of them. One of them, because there was a question earlier about risk factors, one of them, his only risk factor was that he was male. He was not an elderly man. He didn't have any comorbidities. He spent 32 days on a vent and died. And when you have to go to a family and have that conversation, it is gut-wrenching. It is gut-wrenching. They came in with a viral illness, and now they're not going to leave that hospital alive. I cannot believe, and there is such cognitive dissonance about this. I cannot believe that we as a community can't take the step of requiring a mask. I got on the elevator the other day going up to the office, and somebody comes waltzing on there without a mask. And I said, "Where's your mask?" And he goes, I don't need a mask. And I go, "Well, I don't need to ride this elevator with you." And I got off. That's the kind of thing that without a mask mandate, those of us that are interested in trying to keep people healthy are having to deal with. This conversation floors me. I just, from a scientific point of view, it is way off rail. I will be vocal until the day I die about this being the right decision. We need a mask mandate.